Hello, I'm Dr. Wade Sexton, one of the urologic oncologists at Moffitt Cancer Center, and today we'll be talking about a type of urinary diversion called a continent catheterizable diversion. In terms of bladder cancer, this is a very difficult time for you. It's a difficult time to make a decision on what to do once we remove the bladder, and how do we reroute your bladder and reroute the urinary system such that you're able to eliminate the urine. Unfortunately, bladder cancer, there's very little press about it, so we don't hear many celebrities talking about what type of diversion they would like or how they manage their system after their bladder is removed, so it's a difficult time. It's a very private matter for patients. They may be embarrassed about how they eliminate their urine. So again, there's very little coverage about bladder cancer and the effects of bladder cancer when it comes time to remove the bladder. However, to help you with that, we have a team assembled here at the Cancer Center that is composed of our interstomal therapy nurses, who are fantastic and will help you through many struggles. Our nursing staff is quite educated in the management of patients with urinary diversions. Of course, there are other patients, and it's important to speak with other patients who can give you firsthand knowledge of how to manage a urinary diversion. Your cancer surgeon is an important resource. And we'll have differences in the way they manage urinary diversions and different instructions, but by and large those instructions are fairly similar. Finally, home health care nurses will be of assistance, and there are bladder cancer and stoma support groups that will be of great assistance as well. Essentially, there are three types of urinary diversion, and those types of diversion include the ileal conduit, which is where we take a small segment of bowel, and essentially that bowel is led to the abdominal wall where there's a stoma. So you see the bowel at the level of the abdomen. And you would wear a bag or an appliance over top of that stoma, and essentially the urine would drain into that bag and it would be emptied as frequently as you need to. The bag might be changed every 3 to 5 days. A second type of diversion is called a continent catheterizable urinary diversion, and we'll discuss that shortly. A third type of diversion is a bladder substitute, where we again use bowel and sew it to the urethra, which is the tube that drains the bladder out through the urinary tract to the outside world. Again, we at the time of surgery will use your large intestine and create a reservoir that can vary anywhere from 10 to 20 ounces sometimes. And you would learn to catheterize that by passing a small Foley catheter or a tube that goes through the abdominal wall into the reservoir. You would do that every 4 to 6 hours every day for the rest of your life. This is a permanent type of diversion, meaning we do not have any intention of reversing it. You also need to have good ability to catheterize that segment. Now, while everyone needs a little help at the start, and instruction from nurses and stomal therapists, and even help from your family, eventually this is something that you would need to learn how to do on your own. It's important that you are very compliant with catheterizing this type of diversion. Again, it's something that we would do throughout the course of the day. In addition to catheterizing the diversion, you will need to learn how to irrigate that diversion. Anytime we use bowel, the bowel makes mucus, and it's important to irrigate that mucus out of the reservoir on a daily basis. If you can't do that, or if you have fear of doing that, then maybe we need to talk about some other types of diversions. But with the help of the support staff, as I've mentioned, it's something that we feel very confident that you'll be able to master and do well with over time. As I mentioned before, different surgeons will have a different ability and different instructions for you on how to manage that urinary diversion. You may need to catheterize more frequently, depending on how much that pouch holds during the course of the day. You may need to catheterize less frequently, but by and large, the management of this type of diversion is fairly similar, whether or not you have it done by one surgeon or another. And again, you'll want to depend on your interstomal therapist to help you with that transition. In summary, you've elected to consider a continent catheterizable urinary diversion And again, that means the creation of a reservoir that will hold the urine, or a pouch that will hold the urine under the abdominal wall. We will then bring a segment of small intestine, no bigger than a dime or a nickel, up to the level of the skin. You'll learn to catheterize that, and by the way, that's not a painful procedure, okay? But you'll learn to catheterize that every 4 to 6 hours for the rest of your life, and you'll do well, and hopefully you'll have a very normal quality of life as much as possible after this challenging time in your life. Thank you.